Hyponatremia is one of the most common electrolyte abnormalities in clinical practice, yet it's also one of the most mismanaged. The reason is not that the clinicians don't know the causes, it's that they don't have a systematic way of working through them at the bedside. In part 1, we built the physiological foundation of hyponatremia. In part 2, which is this video, we turn that into a single systematic 4-step diagnostic algorithm that can handle any presentation. We'll work through the urine studies and run through two contrasting cases through this diagnostic algorithm and cover some of the pitfalls and examiner pearls as well. And the part 3, the next video, will close up the series with the management of hyponatremia, including the correction rates, which should be the safe correction, use of hypertonic saline, osmotic demyelination syndrome and the pitfalls, and the overcorrection rescue. Now, the 6 key takeaway pearls from part 1. First of all, the rate of hyponatremia matters more than the absolute value. So an acute drop to 128 is more dangerous than a patient with a chronic level of 118. We've already covered this. So again, this is crucial. Number 2, tonicity and osmolality are not the same thing. The urea raises osmolality without raising tonicity, and that distinction drives every diagnostic decision. So please remember that. Number 3, always measure serum osmolality first. It is the first branching point of differentiation of your, the osmolality based on the tonicity based on, hyponatremia. Is it hypotonic? Is it hypertonic, or is it isotonic? And the true hyponatremia is hypotonic. And the next step will then be to assess the volume status of the patient if it's true hypotonic hyponatremia. The clinical bedside examination of the volume status, postal blood pressure, mucous membranes, JVP, we've discussed about it. And that is really, really essential. And then urinary sodium does most of the work of differentiation between appropriate or inappropriate conservation or loss of sodium. And fifth, which ties in with all the 3 states, osmolality, volume status, etc., is the ADH. ADH is at the center of most hypotonic hyponatremias. We have discussed about it before, whether it's appropriate or inappropriate release, or it's extravascular volume overload like heart failure, cirrhosis, plus drugs. So all of them lead to and converge to ADH, which leads to hyponatremia as a final mechanism. As a final result from the final mechanism of ADH. And lastly, do not forget about the pseudohyponatremia. We have discussed it before, and also the drug-induced hyponatremia, which we recently just covered. This is the master algorithm. 4 steps, always in this order, every time. Step number 1, confirm that the hyponatremia is real and repeat the sample if necessary. If pseudohyponatremia is suspected, then run the direct ion selective electrode method like a direct blood gas analyzer and rule out the lab error before proceeding. Step number 2, measure the serum osmolality and assess the tonicity. Is it hypotonic, isotonic, or hypertonic? Most patients will fall under the hypotonic category, which is a true hyponatremia. Step 3, assess volume status. Hypovolemic, euvolemic, or hypervolemic. Clinical examination matters more than any single lab investigation. Step number 4 includes urine studies like osmolality, sodium and chloride read together. They confirm the branch and exclude the mimics. We will walk through each step in detail in the next few slides, and then we will apply the whole algorithm to diagnose a live case. Step number 1 of this process, confirm that the hyponatremia is real before you chase it. So do not think like a techie at this stage of hurrying and rushing. Think of Brady. So Brady means slow thinking, thoughtful process. Repeat the sample if you're suspecting that it's possibly hemolyzed, because hemolyzed sample will read hyponatremia. Anything which suggests a history of pseudohyponatremia, for example, lipemic serum on visibles analysis, history of myeloma, paraproteinemia, or recent IVIG infusion, just run it through a venous gas analyzer, because we discussed in our first video, and please refer to that in more detail, that the direct ion selective electrode method, which is used in VBGs and ABGs, gives a correct reading because it bypasses the dilution artifact which you get with the indirect ISC analyzers in the lab. So how is the diagnostic pathway? If you have a low serum chemistry on the venous on the normal lab sample, but you've got a normal serum sodium on the VBG analysis, which is a direct ISC method, This confirms the pseudohyponatremia. Now, no further workup is needed in such situation, and you just treat the underlying cause, which is the hyperproteinemia, hyperparaproteinemia, hyperlipidemia, chylomicronemia, and all of those. And if once you have confirmed all of them and it's a true hyponatremia, then you proceed to step number 2. After you've done the step 1, now step number 2, serum osmolality. Alternate on every case. It has 3 buckets: hypotonic, isotonic, and hypertonic. The hypertonic category, hypotonic. So think of, bready, slow, less. Hypertonic category is when the serum osmolality is less than 275 milliosmoles per kg. The normal is 275 to 295. So this hypertonic one is the real water excess problem. We've covered it in module 1. So it is subdivided by volume status in step number 3. Remember, most of our patients live here. This is the key core principle. We will discuss about the other 2 in the next slide. The isotonic category, 275 to 295 milliosmoles, we discussed in the last slide and in our video 1. Suggestive of pseudohyponatremia. It's a lab artifact, confirmed with direct ISC test, and stop the algorithm. You do not need to go further. Just treat the underlying etiology. And finally, the hypertonic hyponatremia. Hypertonic, think of techie beetle. Hyper, quick. Okay, so it's actually, as we said before, it's a translocational hyponatremia, dilutional hyponatremia, not a hyponatremia per se, not on its own. Predominantly hyperglycemia causes the water to be pulled out, and that leads to dilution of the sodium. What do you need to do? You need to apply the Hillier's correction formula, which is 2.4 millimoles of sodium increase to every incremental 5.6 millimoles of excessive glucose. Discussed in module 1, video 1, please refer to that. That's a gold standard. And for that, the aurum beetle, the gold beetle, reminds us of the application of gold standard methods. And once you have confirmed the hypertonic hyponatremia, you do not need to treat the sodium, treat the cause. So treat the glucose and the water will follow and the sodium will pick up. Now, once you have done this step number 2 and you confirm that it's hypotonic hyponatremia, which is the true hyponatremia, then you proceed to step number 3. Step 3, assessment of the volume status. Clinical examination first and every time. 4 assessments in a sequence. The first of all, vital signs, heart rate and blood pressure, and most importantly, postural drop in blood pressure, which is for orthostatic hypotension. And remember, tachycardia and orthostasis will point towards hypovolemia. Then comes the JVP and the skin. Easily, if there is a raised JVP with peripheral pitting edema, that points towards hypervolemia, volume overload. However, a flat JVP with reduced skin turgor, and also if there is moist, dry oral mucosa, that would point towards hypovolemia. Next step is the urinary sodium excretion. This confirms the clinical judgment eventually after your clinical exam. So if a urinary sodium of less than 20 clearly means that the kidney is conserving, which is an appropriate response, and that would indicate likely hypovolemia or low effective circulating volume, the ECV, the concept that we discussed in video 1. And a urinary sodium of above 40, on the converse, would indicate renal sodium loss, whether that's an intrinsic renal disease or most likely SIADH or thiazide diuretics. And now, based on your clinical assessment of the patient, as per vital signs, GVP and skin assessment, and the urinary sodium, you can classify your patients as hypovolemic, suggested by our bready turtle, hypervolemic, suggested by our techie beetle, and euvolemic in terms of our AG dove. And that would guide us to the next steps. Step 4, urine studies. 3 tests all read together: osmolality, sodium, and chloride. Never order them in isolation. Urine osmolality answers question number 1, which is ADH on or off? Urinary osmolality of less than 100 milliosmoles per kg means ADH is appropriately suppressed. Conditions like polydipsia or primary water or loading. This means the urine is dilute. Now, urine osmolality of above 100, which means the urine is concentrated, but often it's above 300, as we discussed in our first video, which means that ADH is active. The question is it appropriately active or inappropriately active? We will come to that. This is the single most useful test in a euvolemic patient. The urine sodium confirms the volume branch. If the urinary sodium is less than 20, that clearly means the kidneys are trying to conserve sodium, which is an appropriate response considering the hypovolemia or low effective circulating volume. So the both can be indicated. However, if the kidneys are losing sodium, that is, the urinary sodium is above 40, that likely means that there is a primary intrinsic etiology for the kidneys, with the kidneys, or drugs like diuretics, or it's SIADH or salt losing conditions. Urinary chloride is the trap breaker. Why? Because vomiting leads to bicarbonate which drags the sodium into the urine and pushes the urinary sodium above 20. So this is one condition when it's a dehydrated patient with vomiting. Do not be fooled if the urinary sodium is high. Why? Because it's not renal wasting. It's due to the chloride. So chloride is lost. And then in compensation, the bicarbonate is lost in the urine, which leads to sodium going with it. That leads to urinary sodium being high, although the patient has had hypovolemia from GI loss. So if the urinary chloride stays low, less than 20, that confirms the GI mechanism. So this is the key thing, because you can't rely on sodium in that situation. You have to do the chloride, because now the body is trying to conserve the chloride which has been lost in the gastrointestinal system. Now, this is an examiner pearl. If urinary sodium is above 20 in a clearly dehydrated patient, do not label it as a renal etiology of sodium loss before you check urinary chloride. Now, this concept of bicarbonate urea, chloride testing, and everything I've discussed in more detail in our Module 1 video. Three branches sit under this hypertonic category. Each has its own diagnostic key. Hypovolemic, when urinary sodium splits it. The urinary sodium above 40 means the kidneys are losing sodium, so it's inappropriate. Urinary sodium less than 20 means they're conserving, which means the loss of sodium is extrarenal. So vomiting is a trap we discussed previously. For vomiting, check the urinary chloride. If chloride is low, then it's a GI loss. Euvolemic hyponatremia, urine osmolality splits it. Less than 100 means it's primary polydipsia, because the kidneys are losing the water appropriately. Above 100, mostly above 300 means it's inappropriate ADH secretion or a mimic. Always exclude thyroid and adrenal insufficiency. Hypervolemic, urinary sodium less than 20 means it's a low effective circulating volume, and edematous patient, it would indicate volume overload like heart failure, cirrhosis, nephrotic syndrome, etc. We will discuss each separately. Within the hypovolemic branch of the true hyponatremia, both urinary sodium and chloride can, if read together, they resolve the mechanism. In extrarenal losses, both sodium and chloride will be in urine will be low, because kidneys are trying to conserve. So that means the level will be less than 20 millimoles per liter. Examples include the GI losses from diarrhea, cutaneous losses from burns or sunburns, normal burns, and excessive sweating, and third space sequestration like acute pancreatitis. Now, the vomiting trap we have already discussed many times in this presentation video and the previous one in Module 1, that the urinary sodium in vomiting can be misleading because the sodium can be above 20, and the reason is the bicarbonate urea. In hydrochloric acid loss, the chloride is lost and bicarbonate is going to be excreted to maintain the electroneutrality. So that bicarbonate urea leads to the sodium coming with it to maintain the electroneutrality in the urine. And then that means chloride will be the discriminator. If chloride is low, that means it is GI loss. So this in renal loss, both sodium and chloride in the urine will be high, above 40 millimoles per liter. The causes include diuretics like thiazides, also mineralocorticoid deficiency like Addison's disease, salt wasting nephropathy, the primary renal, and cerebral salt wasting in neurosurgical patients. Let's meet our case 2 to go through the hypovolemic hyponatremia algorithm. A 24-year-old lady, previously well, 4 days history of profuse vomiting and diarrhea after a suspected viral gastroenteritis. She has been drinking plain water freely to keep hydrated, but no oral rehydrating solutions. She's now lethargic, dizzy on standing, and hence reported to the hospital. She's on clinical examination, she's tachycardic at 108 beats per minute, postural drop of nearly 15 to 20 millimeters of mercury. She has got dry oral mucosa, flat GVP, and reduced skin turgor, all indicative of dehydration. Her labs reveal a serum sodium of 121 millimoles per liter, potassium is 3.1, urea is 9, creatinine is 102 micromoles per liter. Both of them are raised. All these parameters are consistent with pre-renal AKI. Her serum bicarb is 34 millimoles per liter. Obviously, 22 to 28 is normal, so that's raised, suggestive of alkalosis from vomiting. Now, before we read the urine, you need to predict the answer. First of all, you need to establish which branch are you in. What do you expect from the urinary sodium and chloride? And you need to hold this prediction. We'll discuss in the next 3 slides. So you can pause here, go back to the algorithm, just work it up, and then we will move further. Okay, so 4-step approach. We will discuss after 2, 3, 4, 5 seconds. Okay, so remember we had the 4-step approach. Step number 1, confirm hyponatremia. In this situation, there is no doubt sodium is 121, so that's below 135, so that confirms. Then step number 2, which is confirmation of the tonicity or hypertonicity in this case. The serum osmolality came back at 254 milliosmoles, less than 275, so it confirms the hypotonia, which means there is a reduction of both water and sodium, but more so in terms of sodium loss, which means the true water content is more than sodium. That leads to the hyponatremia, and it's hypotonic. The other 2 branches, isotonic and hypertonic or translocational, are not relevant in this situation because nothing is suggestive of pseudohyponatremia or hyperglycemia. So that's why we focus our attention to the hypotonic hyponatremia. Step number 3, volume status assessment. We noticed previously that the patient is tachycardic, has postural hypotension of around 14 or 15 millimeters of mercury, and clinically mucous membranes are dry with reduced skin turgor and a flat GVP. There is no edema or ascites. All of them are clearly suggestive of hypovolemia and dehydration. Now, the biochemistry or the initial labs support the diagnosis of pre-renal AKI because urea is raised, creatinine is also elevated, and the serum bicarbonate is 34, which is again corroborates with the vomiting and the loss of acidic contents to the vomiting. Step number 4, urinary studies, which should give us a confirmatory diagnosis. So first one, serum osmolality. We know it's already 254, which is confirms hypertonia. We have looked at it. Urine osmolality is 612. What does it mean? That the kidneys are trying to conserve the water and ADH is on. Urinary sodium in this case is 28. So we would expect it to be less than 20 for volume depletion. So it's a borderline. Obviously, it's a little high. It's not above 40. We'll come back to it later. Urinary chloride is 12. Why did we do it? Because we were expecting GI losses, and in that case, the sodium may not be the confirmatory test or may not be a supportive one. So sodium was borderline high. So now a low chloride clearly means the kidney is trying to conserve. We have discussed about the bicarbonate urea and the sodium trap, so to say. And potassium in urine is also low, which again supports because there is GI loss of potassium. So the kidneys are trying to conserve the potassium. So the final diagnosis for case number 2 is hypovolemic, hypotonic hyponatremia from extrarenal GI loss with free water replacement, which the patient had before. And the urinary chloride is less than 20, which confirms despite the urinary sodium being borderline of 128. So with our MedEd quartet, we've been able to diagnose it. The euvolemic hypotonic limb of the hyponatremia, urine osmolality is the primary discriminator. Less than 100, ADH is appropriately switched off and most likely cause primary polydipsia. The patient is drinking excess water, which the kidneys are unable to, they don't want to retain, and hence they're excreting. So that means it's dilute urine. If the osmolality is above 100, mostly above 300, then it means ADH is switched on and the urine is concentrated. Now, this ADH could be SIADH, the inappropriate syndrome of inappropriate ADH secretion, or it could be an SIADH mimic. Don't settle for SIADH diagnosis as yet. 3 exclusions. Number 1, hypothyroidism. Make sure that TSH is sent. Number 2, Random serum cortisol with or without short synectin test. That is the key thing. You have to exclude adrenal insufficiency. And number three, exclude the drug etiologies like SSRIs, carbamazepines, MDMA, antipsychotics, opioids. We have discussed in extensive detail in our first video. After all these three are excluded, then you might call it as SIADH. But again, you have to apply the Bartter and Schwartz criteria, which we discussed in detail in our first video. So in the three euvolemic diagnoses, all of them, they converge on the same biochemistry, and the only thing separating them will be the urine osmolality. And for example, in primary polydipsia, as we have discussed before, osmolality will be less than 100, which means this dilute urine. Kidney is doing its job. The patient is drinking excessive fluids, sometimes more than 10 liters per day. Clinical conditions like schizophrenia, OCD, or anticholinergic leading to dry mouth. In SIADH, the urine osmolality is above 100, mostly above 300, and the ADH is appropriately switched on. But we cannot exclude SIADH until we have applied the 6 Bartter and Schwartz criteria. Please refer to our video in part 1. The third one is reset Osmostat. It's a variable urine osmolality. ADH is set to a lower threshold because of the patient being in chronic hyponatremia, and the body adjusts or tries to adjust for the lower threshold so that there aren't extreme fluctuations in the ADH release and the sodium. And usually patients have chronic stable hyponatremias of 128, 130, 131. People with COPDs, chronic pulmonary disease, malnutrition, advancing age, dementia, usually doesn't require treatment, but it needs recognition and proper monitoring and close follow-up unless there is an acute trigger dropping it further. So refer to our part 1 video in which I have discussed this reset osmostat in a little bit more detail. One of the key things is that always read the urine osmolality with urinary sodium and the patient's presentation in conjunction to make the final diagnosis. Coming to the hypervolemic algorithm, out of the hypovolemic, euvolemic, and hypervolemic, to be honest, the hypervolemic is probably the simplest of the three. The patient looks edematous, pitting edema, raised UVP, bibasal crackles, ascites, any combination of these presentations. Yet, the kidney behaves as if the patient is volume starved. Why? Because we discussed in part 1 in detail that there is reduced effective circulating volume, or ECV, because of all the different reasons. And with that, the kidney senses it and tries to conserve the sodium. Typically, the sodium is less than 20, especially if it's non-renal etiology. For example, in heart failure, you have a forward flow problem, and that leads to low ECV. In cirrhosis, the splanchnic vasodilatation drops the effective circulating volume. In nephrotic syndrome, due to hypoalbuminemia, there is reduced oncotic pressure and hence reduced circulating volume. Now, in case the urine sodium is above 40, which means it's a primary renal etiology. Okay, so AKI and CKD. In all these situations, the treatment is water restriction, predominantly in the heart failure and all that domain, plus disease-specific treatment, but never saline in such situations, unless and until you have a strong reason of giving like a volume depletion on top of such etiology. Then cautious, careful fluid resuscitation with frequent monitoring might be indicated, but again, follow your local protocols. Our second case is actually from video 1. We will recap it again. The confused nursing home resident, if you can recall. A quick recap on the left side, 78-year-old nursing home resident, 6 weeks ago started on bendraflu with thiazide, presents with acute confusion, clinically not dehydrated, labs showed hyponatremia. So let's work it up according to the algorithm. 4 steps: confirm tonicity, check the volume status, urinary studies, and look at the medications. Okay, so step number 1, it's just academic. So confirm hyponatremia in our patient 118, and there is no other suspicion for pseudo or translocational hyponatremia, so it's confirmed. Step number 2, confirm tonicity. In our patient, the serum osmolality has come back as 248 milliosmoles, which confirms the hypotonic component. Then our next step will be to check the volume status. Step number 3, coming to the volume status. Now, this is a real life like example. It's a bit tricky, so let's come to that. Vitals. Some of you might say there could be some mild postural component to it, but it's a bit equivocal. Blood pressure 132 by 78, 124 by 74, lying and standing. The drop is 8 millimeters in systolic, insignificant. You would require at least 20 and symptoms or 10 diastolic. There is no tachycardia, although the heart rate is not static. So I'm just giving you a little bit of a gray area. So you might argue, or some of the clinicians might argue, oh, there is mild volume deficit. Yeah, we'll come to that. Clinical examination. So vitals, now examination should give you further diagnostic clue. So the patient looks euvolemic because mucous membranes are moist, JVP is not raised, no edema, no ascites, and this now reads euvolemic. The judgment overall should be euvolemia in this situation because most of the signals are suggesting euvolemia rather than hypovolemia. Mild postural drop of 8 could be age-related autonomic dysfunction, not very uncommon at all, and treat as euvolemia. So now the key diagnostic parameters will come from the urinary studies, which is our step number 4. Step number 4, the discriminator, urinary studies and workup. So the patient's urine osmolality has come back as 412, which is again raised. That means ADH driven. Urinary sodium is 52. Kidneys are losing sodium. Again, goes with renal loss, which also indicates could be ADH driven. Let's look at the ADH mimics, SIADH mimics. Thyroid and cortisol, both of them are normal, excluded. Let's look at the drugs reviews. We cannot apply the Bartter and Schwartz criteria until we look at the medications. She's been on thiazide for 6 weeks. So biochemically, it is SIADH, but there is a history of thiazide diuretic. So what is the diagnosis? Finally, let's settle the dispute between SIADH and thiazide diuretics. Well, actually, I cannot do it alone. We'll have to get our MedEd quartet, including our AG. So in this patient, we know it's ADH driven. All the etiology is suggestive of that. There is no doubt about it. Is it thiazide induced because of the temporal association of the drug that she was on, elderly lady, low body mass, etc., etc.? The final verdict is yes, it is thiazide induced because of temporal association. So on the probabilities of balance indicated by our AG Dove and the gold standard criteria by our, AG Dove and the our Aurum beetle, the gold beetle. The Bartter and Schwartz criteria, you have to exclude the drugs as a cause before you can label them as SIADH. So it's not SIADH, it's drug-induced, thiazide-induced hyponatremia. So case 1 is now finally diagnosed. We have thiazide-induced hyponatremia with SIADH mimicking biochemistry. What's the management algorithm? Obviously, stop the offending drug and switch to any other appropriate antihypertensive like ACE inhibitor or calcium channel blocker if appropriate. You can restrict the free water intake to about a liter, 1.2 liters, depending upon patient's body habitus. Recheck sodium in 24 hours and then, every 4 to 6 hourly. And target correction should not be more than 8 to 10 millimoles in any given 24-hour period. This is on up-to-date, this is on clinical guidelines, and follow your local guidelines as well. Do not re-challenge thiazides in future because they've got a very high risk of recurrence. Our part 3, the next video coming up, will cover the safe correction in more detail. 6 traps as a pitfall in this algorithm. I think these are very important examples as well. We've covered most of them already. Number 1, the vomiting trap. We've already discussed that in vomiting, because of the chloride loss through the hydrochloric acid, you cannot rely on urinary sodium, which can still be above 20. So what's the key investigation in that situation? Urinary chloride, which should be low. Number 2, cerebral salt wasting versus SIADH. Both conditions will lead to hyponatremia. And cerebral salt wasting, there will be very high urinary sodium, sometimes above 100, unlike SIADH, which is usually above 40. But the key differentiation between the two is the clinical volume status. In CSW, the patient will be hypovolemic, hypotensive, and hence the treatment is correction with the IV fluids and normal saline, unlike SIADH, where the treatment is fluid restriction. Number 3, the thiazide mimic. So do not forget about the other cortisol, thyroid function testing before labeling as drug-induced or SIADH, to be honest. And in thiazide, the chemistry will be very similar to SIADH, but you have to apply the drug history before you come over to the Bartter Schwartz criteria. So that's another important point. Number 4, acute and chronic hyponatremia. If somebody has got a chronic hyponatremia and suddenly there is a drift, then it has to be taken into account and further investigations need to be done. Number 5 is the correction for hyperglycemia. So Hillier's correction formula, the translocational hyponatremia. So 2.4 millimoles of correction of serum sodium for every 5.6 millimoles per liter increase in the serum glucose above the normal cutoff. So severe hyperglycemia may present as hyponatremia, but that's usually translocational. It has to be corrected. And finally, number 6 is the pseudohyponatremia. Do not miss it. If you have lipemic serum, paraproteinemia, any of those conditions, then use a direct ion selected electrode method to confirm the difference between the lab result versus the result on the VBG. So the algorithm in 6 steps, we need to memorize all of them steps. Number 1, confirm hyponatremia. If you're suspecting pseudo, it will come to the tonicity part as well, but then you can do the direct IAC, VBG, etc. Number 2, once you've confirmed hyponatremia, check the tonicity. Hypotonic, isotonic, or hypertonic. Hypotonic is the pseudohyponatremia we have discussed. Hypertonic is hypertriglyceridemia related translocation that you need to exclude and correct for the hyperglycemia. Isotonic is the one which is in the middle, which is the true hyponatremia. Next step, step number 3, check the volume status. Hypovolemic, euvolemic, hypervolemic. And once you've done that, then urinary studies like osmolality, sodium chloride will lead us to the next category of differentials. And finally, mimics out. Remember to check for hypothyroidism and hypoadrenalism before you label them as SIADH, and also excluding other criteria for SIADH. Remember Bartter and Schwartz criteria. And if the biochemistry doesn't allow you to commit to one particular diagnosis, use your clinical judgment. Subjective, objective assessment. So look at the history, examination, other drug initiation of the drug, the timing, demographics. Usually the simplest and the most frugal explanation is the best one in such situations. Key examiner pearls, we've already discussed most of them. Pearl number 1 is the urine chloride trap. So the vomiting, you should never be confused with urinary sodium. Sodium should technically be low, but if it's above 20, this is a trap. So you cannot label it as, renal etiology. So it is still extrarenal, but it's the bicarbonate urea which is leading the sodium to go with it, and hence that leads to falsely raised sodium. So what is the confirmation test? It's sodium urinary chloride. This confirms the GI loss. Pearl number 2, urine osmolality. In polydipsia, when you're confused whether it's if the ADH is appropriately switched on or not, the urine osmolality tests and gives us a clear indication between polydipsia and SIADH, because if it's less than 100, it's dilute urine, it goes with primary polydipsia, and if it's above 100, mostly above 300, it's SIADH, and the clinical volume assessment will give the diagnostic clue. SIADH will be euvolemic, while polydipsia will be dehydration, hypotension, tachycardia, etc. Pearl number 3 is the correction of the sodium for hyperglycemia. It's a translocational hyponatremia, so Hillier's correction has to be applied before anything else is done. So do not treat the sodium, treat the glucose, and the water will follow, and the sodium should gradually improve. Here we are. Diagnostic algorithm learned, applied in clinical scenarios, diagnostic pitfalls discussed. Remember, diagnosis is half of the work. The safe correction and the management of hyponatremia or the treatment is an equally important other half, where the patients can get some complications if not properly taken care of. The part 3, the next video, will cover the 4 management questions for hyponatremia management. Number 1, the correction rates ceiling, usually 8 to 10 millimoles maximum per 24-hour period. Number 2, when to give hypertonic saline, how to dose it, and what should be the target. Number 3, how to prevent osmotic demyelination syndrome or ODS, and the cliff that the chronic hyponatremia patients usually fall into and fall off. We need to be very careful about that. And fourthly, the overcorrection rescue with dextrose and desmopressin if the sodium has been corrected too quickly. And both of our cases, number 1 and 2, will also need careful consideration for the treatment. We will walk them through in our part 3. So please stay tuned.